Let's talk about TBIs, and this includes epidurals, subdurals, subarachnoids, intraparenchymals, diffuse axonal injuries. Your systolic blood pressure goal is greater than 100 in ages 50 to 69 and greater than 110 in 18 to 49-year-olds or anybody older than 70. And the goal here is maintaining a cerebral perfusion pressure between 60 and 70 to preserve the cerebral perfusion, and hypotension doubles mortality here. Traumatic bleeds are caused by mechanical shear or impact, and it's not an inherently diseased vessel. So the bleeding is often self-limited once the trauma occurs, except in very large vessel lacerations. The main danger here is secondary injury from hypoperfusion, swelling, and increased intracranial pressure. Hypotension is catastrophic here. It worsens ischemia and doubles mortality. So we prioritize perfusion, not aggressive lowering. What if you're worried about herniation? So priorities shift to ICP control here. There are temporizing measures like elevating the head of bed to 30 degrees or hyperventilation with a goal PCO2 of 30 to 35. This is only as a bridge. You can also give mannitol 1 gram per kilogram IV or hypertonic saline. But really what you need is an emergent neurosurgery intervention like a craniectomy or evacuation. Blood pressure management and herniation doesn't really change. You still avoid hypotension, and you may even allow a higher blood pressure to drive your cerebral perfusion pressures if ICP is elevated so that the preserved brain is still getting perfusion. So your target cerebral perfusion pressure is greater than 60, sometimes higher if the ICP is greater than 25. What else can you do in traumatic brain injuries? There are other options than just blood pressure. So think about oxygenation and ventilation. So you want to avoid hypoxia, so keep a PaO2 greater than 60 and SpO2 greater than 94%. Avoid hyperoxia, so titrate down your FiO2 once they're stable. Avoid hypercapnia, so keep the PaCO2 between 35 and 45. Hyperventilation is only for an impending herniation. And again, the goal goes down to 30 to 35, but this is temporary. You can also focus on temperature management, avoid hyperthermia because this worsens cerebral metabolism and intracranial pressure. So treat fever aggressively with acetaminophen and cooling. Normothermia is preferred. Prophylactic hypothermia has not shown a mortality benefit. Also think about glucose control, right? So avoid hypoglycemia, which is anything less than 80. This is catastrophic for those neurons. You also want to avoid hyperglycemia, which is anything greater than about 180. Your target really should be between 140 and 180. You want to focus on seizure prevention because post-traumatic seizures worsen your ICP and secondary injury. Keppra or phenytoin prophylaxis for 7 days in severe TBIs are commonly indicated, but long-term anti-epileptics are only indicated if a seizure disorder develops. If the patients have a hematoma or surgical lesions, you'll want to evacuate the mass effect lesions like an epidural, a large subdural, or a large intraparenchymal hemorrhage, and this relieves ICP and restores perfusion. You also want to think about normotremia or mild hypernatremia because this prevents cerebral edema. So hyponatremia lowers your serum osmolality, so water shifts into the brain tissue and worsens edema and intracranial pressure. Especially in neuropatients, SIADH is a risk, so brain injuries often triggers excess ADH release, leading to water retention and dilutional hyponatremia. You can also get cerebral salt wasting, so brain injuries disrupt sympathetic and renal handling of sodium, and the kidney starts dumping sodium and water will follow. Also think about early nutrition, so within 72 hours has shown better outcomes, and avoid steroids. There's no mortality benefit, you just increase risk of infection and complications.